Ahora sí necesitamos los audífonos, así que quienes no lo tienen pueden salir al foyer para recogerlos. Recibimos con un fuerte aplauso, por favor, al señor David Morgan.
Muchas gracias. Buenas tardes. Now I speak in English. That's it. So I hope you all have your headphones if necessary. I'd like to thank the organisers, first of all, for my invitation here. I'm very honoured to come here to your birthday of 80 years, but more especially to this international forum of looking at financial sustainability. This is very much in the model of what we at the OECD in Paris promote and try to encourage an exchange of knowledge and experience among countries that are along the road in reforms and have built up experience in various areas of the health sector. In fact, only last week there was a meeting in Bogota, very much related to this. Some of you may have been there. And I'll speak about that as well in my presentation today, because it's very relevant to the kind of work that we are doing at the OECD. So what I want to speak about really is some of the experiences from OECD countries and some of the other countries that we work with. I'm working very much, there's a country program between the OECD and Peru, which covers not just the health sector, it covers all sectors of the economy. And it's very much related to benchmarking progress of countries against the OECD countries and in the region as well. And I'm here this week for this conference, but also on a project working with the Ministry of Health in Peru, particularly in the area of health information and how Peru is building towards benchmarking its systems of reporting and being able to monitor its progress in various areas of the health sector compared with other countries as well. So it fits in very well with what's been said already. What I want to talk about today, if I can get this to work. Aha, right. Is to give some of the experience of OECD countries in the areas of financial sustainability and the kind of work that we've done together with OECD countries. The starting point really is to look at some of the, why countries are moving to UHC, universal health coverage, and the benefits that this can bring from the evidence that we've brought from different countries and looking at some of the indicators that are linked to greater population coverage. And just a couple of charts here, for example, is looking at the increase in primary care doctors in particular. And you can see that the strong correlation between the increase in health personnel, particularly in the primary care sector, together with life expectancy, and an overall measure of health outcomes, but an important one all the same. Similarly, particularly in the area of financial protection, the strong correlation you can see regarding the level of out-of-pocket spending, the risk to individuals of having to pay for catastrophic health payments. I mean, there's other areas, straight indicators as well in relation to population coverage and life expectancy. The positive correlations there, correlations between total health spending as well among all countries and life expectancy as well. That's not to say that, of course, we know that other factors outside the health sector are very important as well, such as education. Some of the case studies that we've covered as well, for example, in Thailand, the introduction of universal health coverage resulted in a decrease of 6.5 infant deaths per 1,000 births between 2001 and 2005. Turkey, when it introduced its health transformation program in 2003, saw life expectancy increase by around 4 years over a 10-year period up to 2013. A lot faster this is than many OECD countries as well. And overall, in amassing all the evidence that there's been, if you looked at a period between 1995 and 2008, across 153 countries, the evidence shows that there'd be a 10% increase in, where there's been a 10% increase in government spending, there's been a reduction in under 5 mortality by nearly 8 deaths per 1,000. So that's a starting point. And now I want to move on to what are the key points around universal health coverage. And what are the important points to put in case? First of all, what are the key indicators? Universal has to be in terms of population coverage, then adequate financial protection, but also looking at the basket of services and goods and ensuring not only that there's coverage, but it's a quality of healthcare as well. So excluding health services that are cost ineffective. And then in terms of the financial sustainability, the evidence looks at diversifying the revenue base to take into account, particularly among many populations, the OECD countries, for example, an aging population, and trying to build in various policies to ensure that there's efficiency in health spending. So fiscal sustainability, why are we talking about? Why is it a policy concern? Of course, we're looking at some of the growing cost pressures, and I'll come back to that in a minute. What is pushing up health spending across all countries? There's also the impact of crises and the necessity to tighten the fiscal space that's available for health spending. And there's a lot of evidence, particularly over the last 5 to 6 years, of the impact on OECD countries, particularly in Europe, of the economic and financial crisis. And of course, there's many stakeholders involved in the health sector, right from the patient through to the financing, to the providers and the regulators. As I said, health spending is likely to continue to grow as a share of the economy. If you can see from the chart on the left, this has been across OECD countries, that between 1990 and 2012, health spending outgrew economic growth in all countries. This has changed a little bit in recent years, but it's really seen as just a hiccup. The effect of the economic crisis has slowed health spending in most OECD countries. It's much more in line now with economic growth we will see in the last few years. But our projections of public health and long-term care expenditure as a share of GDP show an increase over the next 20, 30, 40 years. So let's look at the factors of what's driving health spending. As we expand the coverage, there's an increased demand for health services and goods. There's a close correlation between rising incomes, driving higher expectations, and the demand for goods and services in the health sector as well. New technology, new innovations in pharmaceuticals, in processes, in surgeries are increasing health spending overall as well, as it's becoming widely accepted. Of course, as I mentioned before, there's the growing needs of an aging population in many countries as well. Taking Peru as a little bit of an example for looking at some of these factors, as we've mentioned before, there's been a strong growth in coverage over the last 10 years or so through economic reasons, as more coverage has come into EsSalud, but also in expanding the services and the coverage for the poorest of the population as well. And this has very much been linked to or resulted in a reduction of some of the barriers that individuals face in seeking care and seeking health services. And in particular, when I talked about the financial risk, financial protection, and the link to the out-of-pocket payments and out-of-pocket expending, you can see how much it has fallen over the last 10 years in the reasons why people were not seeking care. So there's a drop from almost a quarter of citing the reason as of lack of money down to less than 7% over a period of 10 years. So talking about the effect of aging, life expectancy is increasing both because of birth, lower infant mortality, but also the increase of old age as well. This chart shows that how many years it has taken for a doubling of the population aged 65 and over in various countries around the world. At the top, it took France about 132 years up to the early 90s to double that share of the population aged over 65 from 8 to 16%. 67 years it took for the USA for the same doubling up to about 2010. Japan has seen a very rapid doubling of the elderly population over the last 20 or 30 years. And this is not just a phenomenon in OECD countries. We see the average is 63, but it's very much on the agenda for a lot of the emerging economies, which will face this problem in the future, in the next 20 to 50 years or so. We'll see overall, we can see Brazil is expected by around 2030, 2035, in a period of 22 years to have doubled the elderly population, and similar figures for China and Indonesia. And this will put an enormous pressure on the health services and health expenditure as well. And of course, in looking at how to sustain financial system in health and who is paying for it, this will show that the impact and the ratio of the elderly population compared to the working age population for the world as a whole will see a complete reversal, where it will go down over the next 20, 30 years, where there won't be the sufficient body of workers to support the elderly population, and so the need to diversify the range of financing sources in any health system. If we look at OECD countries, you can see that health spending has already a major share of total government expenditure. The OECD as a whole, it's about 3/4 of health spending is coming from public sources, maybe either depending on the type of system, whether it's government spending or a social security type of system. Even for some of those other countries that, for example, the BRICS countries, you can see that around about half of health expenditure is coming from public sources in most cases. If you turn that to the Latin American countries in the region, there has been an increase as coverage has grown of the public sector bearing more of the burden of health spending. So that in the most case and around the average, you'll see that about 50% of health spending will be from public sources. So the question comes to us about why is controlling expenditure on healthcare such a challenge? From the budget officials within the Ministries of Health, is typically seen as one of the most complex areas of expenditure control. And there are various reasons for this, specifically for the health sector. First of all, health is a very high priority for citizens themselves, along with education, etc. As I mentioned before, there are many stakeholders involved in the health sector, from the beneficiaries, the patients, through to the range of different providers, hospitals and GP surgeries, etc., pharmaceuticals, pharmacies, up to the differences in financing and regulation as well, whether it's through government schemes, tax-funded schemes, or through types of social insurance contributions. And of course, that links to the great institutional variations in operating these various different types of health systems. So a lot of the work of the OECD has been quite innovative in getting networks of countries to meet together, bringing together officials from the Ministry of Health and health insurance institutes, together with the ministries of finance as well, so that they start to speak the same language. And this has been a project of the OECD over the last few years to build a body of evidence on financial sustainability of health systems through this network of ministries of finance and ministries of health. And this has been through various mechanisms of looking at country case studies, for example, a survey of health budgeting methodologies and tools that are in place to control and monitor spending in the health sector, as well as specific thematic analysis of looking, for example, at the impact of aging on health spending. So this has really culminated in a network of meetings around the world globally. As I mentioned, only last week, there was the first meeting of the Latin American senior budget officials and health officials joint network in Bogota. There have been other meetings in some of the other areas, other regions of the world. There's an annual meeting in Paris bringing together, though, mostly the OECD countries. But it's this kind of model has been exported to other areas of the world very successfully in Southeast Asia as well. So this body of work has really come together into a framework looking at the fiscal sustainability of health systems. And it's broken it down into 3 steps. First of all, the first step would be a diagnosis. What are the information needs of the system? What are we looking at? What can the information that we can get out of the system in terms of financing and spending be used for? And the type of information needs that we're talking about are long-term forecasts of health spending, both spending and revenue sources, medium-term spending requirements in a kind of 1 to 5 year time frame, very much monitoring the information on executed budgets and up-to-date, timely information on health expenditure as well, and linking these various types to revenue estimates as well, to really get a good handle on the revenue side of how to match the expected spending on health services in the future. The second step that has been identified is looking at some of the risk factors that impacts on these. So it's looking at the various political and institutional contexts that play a part in the financial sustainability of health. And the key points to make here is the political agreement on various targets of health expenditure, building some mechanism of coordination between the various stakeholders within the system, so building a dialogue that will impact on the success of the health system, analyzing the degree and the impact of decentralization in various health systems, and looking at what the boundaries and the split between the public and private spending and how this impacts on health systems as well. So when I talked about the various areas of analysis, these, particularly the last two on the decentralization and the public-private split, is some of the areas which have been looked at. And then the third part is what are the treatments? What are the type of policy tools and policy instruments that can be used in adjusting and monitoring and having an effect on the health system? So we can look at various areas from the supply side, evidence from various payment methods, the introduction of generics in the pharmaceutical sector, placing budget caps on spending as well. From the demand side, getting a better handle on controlling demand through positive preferred drug lists in areas, the introduction of gatekeeping from primary physicians into specialist care or hospital care. Some of the impacts from a public management perspective and point of view, from coordination and financing, particularly negotiations in the area of drug prices and referral prices in the area of pharmaceuticals, the use of health technology assessments, to what extent new technologies coming into the market are cost effective, and will impact on health spending. And then finally, looking at the revenue side and the need to diversify some of the sources of revenues to sustain the financial system. So a couple of points to add here. The financial sustainability of health systems is very much obviously a political question as well. There's a public demand for good quality health services, and that will make, as we've said already, that puts an additional cost pressure on public spending on health and making it harder to control. And future support for government spending on health will obviously be shaped by the views on redistribution as well, from richer to poorer, as much as the economic drivers of future revenues as well. Okay, so saying all that, then you can come up with an easy solution to fiscal sustainability. The easy answer: make the patient pay more. The doctor here is saying, "Oh, I'll have someone in and prepare your bill for you," rather than for your operation. But that's it's how you achieve financial sustainability that matters. This might be a bit flippant. So what are the answers? What are the various options to governments, to the stakeholders, to funders of health spending? When we look at the pressure on public budgets. First option, there's possibility to reallocate public funds from other areas of public spending, or raise new funds themselves. Now, there's question marks over the efficiency or the feasibility of this option. Already, health takes, on average, among OECD countries, it's about 15% of government spending. So it's already a large chunk, and the feasibility of squeezing out other areas of health spending is limited. It could be as much as 20% in countries such as even in the US or in Switzerland as well. Raising new funds, looking at other areas of tax or different areas of revenue streams as well, places some question marks over its feasibility or efficiency. An obvious answer is to improve the value for money for what is being spent already. And as I mentioned, some of the examples from here in better procurement practices on pharmaceuticals, the introduction of generics. We at the moment, I'm very involved in a project at the OECD looking at waste within the health sector as well, ranging from administrative waste in the duplication of activities between various systems, in both financing and provision, to looking at some of the operational waste. Is care being provided in the right place at the right time? So there's certainly areas for work in improving the value for money within the health system as well. And finally, as I mentioned before, is to reassess some of the boundaries and look at the basket of services and goods which are included under a public system and how the private spending can interact with that. Of course, there's some worries here about the equitable nature of that when you increase cost spending, for example, across the board, and the feasibility and the efficiency of these kind of measures as well. In terms of the other part of the work which was being done in some of the short-term monitoring of health spending, as I mentioned, there was a survey of the budgeting practices across OECD countries as well, and the introduction in a lot of areas of what we call early warning systems of monitoring health spending against budgets and the need to adjust and correct. And we can see that there was a wide variation in the time lag that various countries would take in reporting health expenditures to a central budget agency to monitor the real-time spending, if you like. This would range from almost instantaneous real-time from countries in Korea, for example, which would have an up-to-date monitoring of health spending throughout the country, ready for budget officials to act on if necessary, to adjust, through to, in some cases, this kind of information not being available for 12 to 24 months after the reference period, which leaves very little room for any adjustments in public expenditure monitoring. The work that was done on fiscal sustainability happened at a time when a lot of OECD and European countries were facing the impacts of the global economic and financial crisis. And so this provided a lot of evidence and experience on what kind of measures in the short term countries were taking to rein back their public budgets in the line of a reduced fiscal space. And these country responses to the crisis had to be, in some cases, very short term to cut administrative spending or staff in the health sector. And some of these were considered long overdue. For example, in Greece, where pharmaceutical spending had traditionally been very high, amongst the highest in the OECD, but had been very efficient. So it forced some certain innovations and reforms to take place, particularly in the pharmaceutical area, of better procurement practices, removing some of the inefficiencies in prescribing, better guidelines. And these could be seen as being good in the long term, even though they were introduced in short-term measures. Other interventions were seen as risking having an impact on some of the access, or even increasing costs in the long term. One of the aspects we really noticed in analysing health spending over this period was, in contrast to what was often publicly announced in ring fencing and protecting budgets related to prevention, then often public health campaigns or prevention activities were one of the first areas where it was easy to postpone or to push back. And as I said, this would have is beginning to see some impact in some of the outcomes in countries as well. Other interventions which could be seen as risky in the long term was an introduction of cost sharings, and this would have a particular impact on equity of access across the health system as well. Some countries, from the work that had been done, had been seen to take more of a longer-term perspective. For example, in France, spending targets had been in place since 1996. And part of this was to have parliamentary approval for setting the spending targets. There was a monitoring and feedback mechanism, which has been seen over time to bring dividends to the control of health spending in France. And it's also led to a realization of broadening the overall revenue base in the country, to move away from employment-related contributions to other areas of indirect taxes and out of the government general tax regime as well. I won't go into all the details here of the kind of work and the experiences that were garnered through this project over the last few years. But just to point to some of the areas where we looked at, and particularly in the impact of decentralization on fiscal sustainability and health spending, and the role of subnational governments in this area. I've touched on it already, but some of the actual empirical evidence that you can bring on cost containment. Again, specific case studies looking at some of and gathering of evidence from countries on what have been the responses to particularly the global financial crisis, but other crises that have hit specific countries as well. A huge area, as I mentioned already, would be the impact of aging on health financing as well. And this is supplemented by more in-depth case studies, particularly on France and the UK and the Netherlands. So I can finish with some concluding comments from the range of evidence from OECD countries. We've seen that health spending is likely to continue to grow as a share of health of the economy, particularly as universal health coverage is pursued or maintained. This is likely, as I've showed, to put a greater pressure on public budgets as the share of health spending coming from public sources increases as well. So the challenge, as I've said, and I put out some various options, is for governments to respect the fiscal sustainability constraints and look for options of how to manage this. And I think the lessons from OECD countries, as well as from the various networks which I've talked about, and again I encourage and promote the knowledge exchange of experiences between countries, can help the learning process and to build in and understand the risk of fiscal sustainability. So I think with that I can finish my presentation. Thank you very much.